Bismillah ar-Rahman ar-Rahim. The ankle actually is one of the simplest joints in my opinion. This is the most simple one. Yes, you will see it. That is a very simple joint compared to the knee and to the shoulder. The ankle is very simple in approach and in diagnosis. There are few lesions around the ankle, and you can easily manage in a simple way, as I'll show you to you. Then you remember these machines, and this open magnet is suitable for examination of the ankle. And this is the coil we use, and it is used for fixation of the foot, and you can also fix the foot with some sponge here. These are the protocol for examination of the ankle joint. What is the most important issue in all of these is the field of view, and this is the major problem we have. Usually the operator do not stick for the small field of view, because it makes the examination lengthy, and they want to finish up with the patients quickly. Then they increase the field of view, then the anatomy will be very small and you cannot identify any of the anatomical landmarks. Then the usual field of view for the ankle ranges from 8 to 12 centimeter. This is the optimal field of view, and if you are in a charge, you should insist for this in order to get some images that you can interpret. Then what do you think about these examination planes for the ankle? Which is the most suitable? And you see in the knee, the most suitable plane of examination is the sagittal. In the shoulder, you see some go with the axial and some go with the coronal sections. They are very important. But in this ankle in particular, the axial images are very important. The axial images are important. Then how to know the pulse sequence? When the bone marrow is bright, this is T1, less bright, this is T2, more dark, this is gradient, very dark, and this is the stair images. And also you remember this rule: the non-mobile protons, including the cortical bone, the ligaments, I'll see the ligaments, then the tendons, the calcium, all of these appear black in the T1 and T2 weighted images. The fluids appear black in the T1 and bright in the T2, like the fluids around the tendon sheaths, for example, synovial effusion. Then the fat, which is the reverse of the fluid, the fat appears bright in the T1 weighted image and less bright or dark in the T2 weighted images. Then this is the policy how to deal with the ankle. The policy how to deal with the shoulder is you identify the anatomy. You see, and I would like to see tendons, I would like to see ligaments, bones, bursa. This is not the rule for the ankle. The best rule for the ankle is you divide the ankle into 4 components or compartments: the anterior compartment, the posterior, the medial, and the lateral. Then each of these compartments has tendons and ligaments. Each of these compartments have tendons and ligaments. But the posterior and anterior compartments contain tendons only. There is no ligaments, unless there is no ligaments anterior and posterior, but the ligaments are located medial and lateral. Then you remember the posterior compartment contains tendons, the anterior compartment contains tendons, but the medial and lateral compartments contains tendons and ligaments. Then we start the evaluation of the posterior compartment, and in the posterior compartment there is only one tendon. There is no ligaments, and this is the Achilles tendon. Okay? Then this is the simplest way to assess the ankle. You start by the posterior compartment, assess the Achilles tendon, then you go to anterior compartment, medial and lateral. Okay. In the posterior compartment, you see the Achilles tendon, which is black in the T1 and black in the T2. This is the strongest tendon all over the body, but it is frequently injured because of its superficial location. And you can see here, this is the tendon, which is black in all pulse sequences. And you can imagine that the axial images are the best for evaluation of the Achilles tendon. The axial images are the best for evaluation of the Achilles tendon. And here you can see the tendon is intact, but you should go to the axial images and to realize this appearance. The anterior part of the tendon should be flat or concave. If the anterior part of the tendon is convex, you are dealing with an abnormal tendon, in spite of the signal. Then if you see the tendon like this is an intact tendon. Uniform signal, flat anterior surface, convex posterior surface. then the rupture of the Achilles tendon is easily identified in the sagittal and in the axial images as well. When the tendon rupture, you should say these facts. Where is the site of the rupture in reference to the insertion site in the calcaneus? The distance between the cut edge and the insertion site in the calcaneus. Number 2, the gap between the cut edges. Like the supraspinatus, you should specify for the surgeon the gap between the cut edges of the tendon. Then you should say, or you may not say, what is inside the gap, fat or fluid or blood or both. These are the important items to be fulfilled with rupture of the Achilles tendon. Then here you can see this is the rupture of the Achilles tendon, and the tendon is corrugated, and this rupture had been repaired before and re-ruptured once again. And if you go to the axial images, you see the normal tendon on the left side and the abnormal tendon on the right side. You see abnormal signal and you see abnormal configuration. Another case of rupture of the Achilles tendon, and you see the tendon is markedly swollen, and there is a gap starting in between these two arrows, and the gap is filled with something which is bright in the T2 and black in the T2, this is fluid, and something which is bright in the T1 and black in the T2, which is fat. Then you know that this rupture extends from this distance, and it is away from the insertion site by about 1.5 centimeter, for example, and the gap is filled with fat and fluid. Then if there is a partial tear, you should go to the axial to assess. You see here, this is the normal tendon, and in this area you can see the tendon is swollen, and there is a bright signal in the T1 and a bright signal in the T2, meaning that there is blood in the site of the rupture. Then the tendon being thick and strong can be partially torn. Then if you see here, you see some fibers that are intact, some fibers are torn, and you see fluid in the site of the tear. Also here you can see this is the Achilles tendon, and you see this very bright signal which is specify rupture or partial rupture of the tendon fibers. Then if you look to the Achilles tendon, you should know that the Achilles tendon has no synovial sheath. There is no tenosynovitis of the Achilles tendon, but there is tendinitis and tendon degeneration and peritendinitis. There is no tenosynovitis. Then if you look to the Achilles tendon and you see that the tendon is swollen and there is an intermediate signal like the signal of the supraspinatus, then you are dealing with degeneration of the Achilles tendon. In this area, you can diagnose tendinitis without the presence of calcium in the Achilles tendon, but in the supraspinatus tendon, no. Then look at this tendon. You see the tendon is swollen and you cannot see any abnormal signal inside. This tendon is relatively swollen and you see a very bright signal. This is tear. This is partial tear. But intermediate signal or no signal but a change in the caliber of the tendon are diagnosed as Achilles tendinitis. Then this is the difference between tendon degeneration or tendinitis of the Achilles tendon and the tear. You see the tendon is swollen and there is bright fluid signal inside the tendon denoting partial tear, and this is tendon degeneration or tendinitis of the Achilles tendon. Then you know that there is a small bursa between the insertion site of the Achilles tendon and the posterior aspect of the calcaneus, and this bursa is normally filled by minimal fluid. Then this is the site of the bursa in the axial images, and this is the site of the bursa in the sagittal images. And if you look here, this is inflammation of the bursa. You got more fluid in the bursa, black in the T1, bright in the T2, and you see the amount of fluid in the bursa is enlarged. Then you got what we call retrocalcanean bursitis. This is a case of rheumatoid arthritis with retrocalcanean bursitis, a very common association. And you see that the bursa is filled of fluid, it is enlarged, and the fluid is very bright signal in the T2 weighted image. This finishes the first compartment, which is an easy compartment. Then you go to the lateral aspect. In the lateral aspect, you have ligaments and tendons. In the lateral aspect, you have ligaments and tendons. First, how to identify the lateral aspect? By the presence of the fibula. Then this is the axial image of the ankle, and you see this is the site of the fibula, and this is the tibia, and this is the talus. And here you see this is the site of the fibula. Then in the lateral aspect there are ligaments and the tendons. The tendons on the lateral aspect are the peroneal tendons, which are the peroneus longus and the brevis. Then if you see, this is the fibula, and this is the fibula as well, and you can see two small structures posterior to the fibula, and these are the peroneus longus and the brevis. You see here, this is the peroneus longus and the brevis, and they cross posterior to the tip of the fibula. Then, which is the brevis and which is the longus? The peroneus brevis is anterior and medial. The peroneus brevis is anterior and medial to the longus. And this is very important because the brevis is frequently torn while the longus is not. Then you should identify in the axial where is the brevis, and the brevis is medial and anterior, and the longus is lateral and posterior. Then these are the this is the fibula, and these are the tendons. This is the brevis, which is anterior and medial, and this is the longus. And you remember that the peroneus longus will show the magic angle phenomenon, like the supraspinatus. These are the only tendons in the body showing this phenomena, which is the magic angle, and you can see this abnormality in the T1, and you don't see it in the T2 weighted images. And you remember also that there is less frequent injuries of the peroneus longus compared to the peroneus brevis. Then if you look to this ankle region, and you see this is the fibula, and you see two tendons. The anterior one is the brevis. The posterior one is the longus. Then you see here, and in this area, I hope you can see that there is a tendon, only one tendon, and there is an edema or fluids around this tendon, and the second tendon is missing. Then you can say safely that it's the tendon of the peroneus brevis that has been torn. Then sometimes this is also a normal variant in the peroneus brevis and in the biceps tendon. Normal splitting. The tendon may be splitted congenitally. Then you see that there is a peroneus longus and two tendons corresponding to the peroneus brevis. And if you don't have a history of trauma or signs of trauma like bone marrow edema, soft tissue contusions, and fluid signal, and this is a congenital variant. Then what about the ligaments? There are two sets of ligaments on the lateral aspect. The first set is known as the lateral collateral ligament, and the second set is known as the syndesmotic complex. Then we start first by the one which is very important. It is the lateral collateral ligament. The lateral collateral ligament is formed of three components. The syndesmotic complex is also formed of three components. ولكن يعني it's extremely easy. Then how to identify first the lateral collateral ligament? Then you go to the lateral aspect of the ankle, and you identify the fibula, and you look for the fibula for this groove, a medial groove. You see in this area, you see a concavity on the fibula. If you identify this concavity, you are at the level of the lateral collateral ligament, which is formed of these ligaments: the anterior talofibular, the posterior talofibular, and the calcaneofibular. Where is the anterior talofibular? This one. This is the anterior talofibular ligament. Where is the posterior talofibular? It is coming from the groove posteriorly. This is the anterior talofibular, and this is the posterior talofibular. The anterior talofibular is the most constant ligament in the ankle at all. And you should identify this ligament in any examination, whatever bad it is. Then, if you see the fibula, you should identify the groove. Then you see a ligament coming from its anterior aspect. This is the anterior talofibular. And coming from the posterior aspect, this is the posterior talofibular. Because this is very constant and seen in every examination, it stands for the lateral collateral ligament. Whenever you say injury of the lateral collateral ligament, you are meaning that the anterior talofibular ligament is torn. Okay? Then, where is the calcaneofibular? It is not usually seen because it cannot be cut in a single blade. Then you see part of it, and it is not important in the evaluation. Then the lateral collateral ligament, you see the fibular groove, then you see the posterior talofibular and the anterior talofibular. The same issue, the anterior talofibular and the posterior talofibular. Then if you look to this normal appearance, they see this is the fibular groove, is clearly seen, and this is the anterior talofibular. Where is the posterior talofibular? It can appear in another image, and you should look in the previous or in the coming image. Then if you see this examination and you see this is the fibular groove, and coming out of the fibular groove, the posterior talofibular. If you look for the anterior talofibular, you cannot see, and you can see fluids at the site of the ligament, meaning that this anterior talofibular ligament is torn. Then sometimes this is the normal anterior talofibular, posterior talofibular. Sometimes you look at the anterior talofibular and you find it very, very thick, but then the signal is preserved. And this, you remember, every now and then anyone can sprain his ankle, and this sprain causes some minor injuries in the ligament, and after fixation and less weight bearing, the ligament repairs itself. And by time you got a very swollen tendon but of normal signal. This is known as chronic injury of the lateral collateral ligament or of the anterior talofibular. Then this is an old technique to see the talar tilt angle, and if you tilted the foot like this and you measure the angle between the tibia and the talus, this angle is normally less than 40 degrees, and there is a minimum of 10 degrees or the maximum of 10 degrees variation between both. But if the lateral collateral ligament is torn, then you expect that this angle will be increased. Nowadays, we do not refer for this because of the limitations of pain, the force of the examiner, and the laxity of the normal leg. Then you came to the syndesmotic complex. The syndesmotic complex are ligaments coming from the fibula to the tibia. Then we call them the tibiofibular. Okay. Then the tibiofibular are also three: the anterior, the posterior, and the transverse. Don't bother yourself with the names, but if you imagine the talus in relation to the tibia, the talus is inferior to the tibia, okay? Then you see the lateral collateral ligament or the talofibular ligaments at inferior plane, and when to look to the tibiofibular ligaments at the superior plane. Then if you identify the fibular groove, then you are at the level of the lateral collateral ligament. Then go above by two sections only, Then you see the fibula like this, and you will see a ligament coming from its anterior aspect. This is the anterior tibiofibular, and another one coming from its posterior aspect. This is the posterior tibiofibular. The inner fibers of this posterior tibiofibular is this one, which is the inferior transverse ligament. It is a component of the posterior tibiofibular. Then, if you look here to the site of this fibula, this is the tibia, of course, and this is the medial malleolus, and this is the lateral malleolus. Then, at what level are you now? Is it the fibular groove? No, you are above. Then, this is what? Anterior tibiofibular, and this is what? Posterior tibiofibular. It is clearly seen here. Then, I'll come back to this anatomy once more. Okay, then we go to the anterior aspect where there is only tendons. There is no ligaments in the anterior aspect. And in the anterior aspect, you got the extensor tendons. I'm sorry for this. This is extensor tendons. And you have three muscles: the tibialis anterior, the extensor hallucis, and the extensor digitorum. Then you see these muscles. This is the tibialis anterior, this is the extensor hallucis, and this is the extensor digitorum. If you look posterior to the tibia, you will see also three tendons, which have almost the same names, but the flexors. They are the flexors. Then, the tibialis anterior is intimately related to the tibialis posterior. They are at the same plane. This is the tibialis anterior, and this is the tibialis posterior. Then you reverse the names of these. And instead of this is the extensor hallucis, this is the flexor digitorum. And this is the extensor digitorum, and this is the flexor hallucis. How to remember this in a very simple way? forget about the sentences and the بيت الشعر والكلام ده كله، انسى الموضوع ده. You just remember that the tibialis anterior is related to the tibialis posterior, okay? Then you know that the most largest muscle on the posterior aspect of the ankle is the flexor hallucis. The flexor hallucis. Then you know this is the flexor hallucis, this is the flexor digitorum, and this is the extensor hallucis, and this is the extensor digitorum. That's all. And you know that the tibialis posterior and the anterior are on the same line. Then the largest muscle here is the flexor hallucis, then this is the flexor digitorum, and this is the extensor hallucis, and this is the extensor digitorum. And you remember, this is the Achilles tendon, and this is the peroneal muscles. This is the peroneus brevis, which is medial, and this is the peroneus longus, which is lateral. Then here you can see the muscles. This is the tibialis anterior, وبعدين extensor hallucis, بعدين extensor digitorum, and the tibialis anterior tendon is swollen with fluid signal and abnormal signal inside. This is traumatic, post-traumatic injury of the tibialis anterior, which is rare. This tendon is relatively rarely injured. Then this is another example. What do you think about this? Is the fibula. At what level are you? The lateral collateral or the syndesmotic? Yes, and this is anterior tibiofibular, and this is posterior tibiofibular. And this is the tibialis anterior, and this is the extensor hallucis, and this is the extensor digitorum. Okay. Then you came to the medial aspect, where tendons and ligaments are located. We already finished with the tendons, which are the flexor tendons, which are the tibialis posterior, the flexor digitorum, and the flexor hallucis tendon. Then the medial tendon, which is located here, is known as the medial collateral ligament or the deltoid ligament. We start by the tendons because the tibialis posterior is frequently injured, and you have 3 types of injuries in the tibialis posterior. The 3 types, type 1 means hypertrophy of the tendon. The tendon is markedly enlarged. Then what is the reference for you? The tibialis posterior is normally twice the size of the flexor digitorum or the flexor hallucis. If it is 4 times or 5 times, then you know that this is type 1 tibialis posterior injury. This is type 1. Type 2, the tibialis posterior is split into 2. The tibialis posterior is not split congenitally. It is split only post-traumatic. And type 3, you cannot see the tendon. It is completely torn and you don't see any structure at its anatomic site. This is the type 1 injury where you can see the tibialis posterior tendon, which is swollen with abnormal signal. Compare with the flexor digitorum, the nearby tendon. The flexor digitorum tendon is about 1/4 of this tibialis posterior, and you can see abnormal signal. This is type 1 injury. And this is type 2. If you look here, then you can see on the medial aspect, this is the tibia, and this is the medial malleolus. Then you should see on the medial aspect 3 tendons, which are the tibialis posterior, the flexor digitorum, and the flexor hallucis. But here you can see 4 tendons, and these 2 belongs to the tibialis posterior, which is a splitting of the tibialis posterior tendon. Also here you can see the flexor hallucis, the flexor digitorum, and the 2 tibialis posterior tendons representing type 2 injury of the tibialis posterior. Then a few words about the tenosynovitis. Tenosynovitis means fluid around in the tendon sheaths, and the tenosynovitis is very common in the ankle. In cases of acute tenosynovitis, you see fluid, but in chronic cases, you cannot see fluid and you see organized granulation tissue. But you should remember, in the shoulder, the biceps tendon communicates with the joint. In the ankle, the flexor hallucis longus communicates with the joint. If you see fluid signal around the flexor hallucis longus tendon, then you go to the ankle joint. If you do not see fluid inside the ankle, this is tenosynovitis of the flexor hallucis. If you see fluid in the ankle and the fluid around the tendon, then these are the normal distribution. Then whenever you see an ankle like this, and you know that this projection from the calcaneus is known as the sus tentaculum tilli. The sus tentaculum tilli usually is projecting medially. And in absence of the fibula, you can identify the medial aspect of the joint by the direction of the sustentaculum tali. This is the medial aspect of the joint, and this is the lateral aspect of the joint. What do you see on the lateral aspect of the joint? The tendons are peroneus longus and the brevis. What abnormality you see here? Fluid in the T2. You can see fluid around the peroneus tendons, but you see the peroneus tendons are 3 instead of 2. Yes, okay, and the anterior one is split into 2, and this is the normal splitting of the peroneus brevis. And all the tendons, because the tendons before the tip of the fibula have a common sheath, and after the tip of the fibula, every tendon has its own sheath. Then this is the acute tenosynovitis of the, which tendons are these? Yes, this is the peroneus tendon. Which one? This longus, and this is the brevis. And do you remember this ligament? Anterior tibiofibular. Very good. And this one? Posterior tibiofibular. And this is acute tenosynovitis because of the fluid signal around the tendon. But here in the T1 and in the T2, you do not see fluid. You see only granulation tissue. It is not bright in the T2 with the image, and this is chronic tenosynovitis of the peroneus tendons as well. This is the brevis, and this is the peroneus longus. Then the deltoid ligament is not that detailed like the lateral collateral ligament. The deltoid ligament is usually a very complex structure, and you just know its anatomic site. And if the tendon is injured, you will see fluid at the site of this ligament. And usually this ligament is not surgically repaired, so that you can only say there is rupture or injury of the medial collateral ligament. You cannot see in details the full fibers of each tendon, because this tendon has this ligament has connections with the tibia to the talus, to the navicular bone, and to the calcaneus. And the best way for evaluation of this tendon is the coronal images. In the coronal images, you identify the medial malleolus, and you see fibers of the ligament coming from the medial malleolus to the talus and to the calcaneus as well. And you can see here, this is one of the ligaments coming from, part of the ligament coming from the medial malleolus, the tibia, to the sustentaculum tali of the calcaneus. And this is another one coming from the tibia to the talus. This is the only plane where you can easily judge the possibility of rupture of this medial collateral ligament. Then you came to the one of the anatomic landmarks, which is the sinus tarsi. The sinus tarsi is the space between the talus and the calcaneus. And the sinus tarsi is usually containing fat and 2 ligaments. One is long and one is short. The long ligament is attached to the neck of the talus and is known as the cervical ligament, while the short one is seen at another plane and is known as the interosseous ligament. There are only 2 ligaments in the sinus tarsi, the cervical ligament and the interosseous ligament beside fat. And you can see this is the sinus tarsi, and you can see the two ligaments as well as the site of the fat. How can you diagnose sinus tarsi syndrome? Either you do not see the ligaments, or you see anything instead of fat. Fluid, granulation tissue, tumor mass, anything instead of fat, then you can diagnose sinus tarsi. What are the causes? Ligamentous tear, synovitis, osteoarthritis, ganglion, cyst, or gout affecting this area. In the stair image, you can see the ligament, which is the cervical ligament, and the fat is black because this is a stair image. And in this case of a sinus tarsi syndrome, you cannot see the ligaments, and you can see fluid inside the sinus tarsi. Then you are diagnosing the sinus tarsi syndrome. Another case of sinus tarsi syndrome, you cannot see the cervical ligament nor the interosseous ligament, and you also see some fluid signal inside the sinus tarsi. Also, you can see the sinus tarsi in the axial view, because the sinus tarsi is present between the talus and the calcaneus, and this is the talus and this is the calcaneus, and here you can see the site of the sinus tarsi. It does not contain fat, and you cannot see the ligaments. Then you know that this is the sinus tarsi syndrome. Also, you remember this is the lateral aspect. How do you know? Because this is the sustentaculum tali pointing medially. Then you know these two ligaments are the peroneus tendons. The anterior one is the brevis, and the posterior one is the longest. If you look carefully in this particular plane, and you can see a very small line which is part of the calcaneofibular ligament. You remember the lateral collateral ligament is formed of three parts: the anterior talofibular, the posterior talofibular, and the calcaneofibular. And this is the only segment of the calcaneofibular you can see underneath the peroneus tendons attached to the calcaneus. Then this is a case of sinus tarsi syndrome. You see the sinus tarsi is filled by fluid, and you cannot identify clearly the sites of the ligaments. Then what about the tarsal tunnel? The tarsal tunnel is like the carpal tunnel. The tarsal tunnel is on the medial aspect of the ankle. Its floor is bony, formed by the talus and the calcaneus, and its surface is fibrous, formed by the fibrous retinaculum. What are the contents of this tarsal tunnel? There are the flexor tendons, tibialis posterior, flexor hallucis, flexor digitorum, and the neurovascular bundle. Then if you would like to see the anatomy of this tarsal tunnel, you should go to the sustentaculum tali. This is the site of the tarsal tunnel. Inside the tarsal tunnel, you will see the three tendons, which are the tibialis posterior, the flexor digitorum, and the flexor hallucis longus. The tarsal tunnel is covered by the flexor retinaculum and an important muscle, this muscle. This muscle, in order to remember its name, it is abbreviation is ABH, abductor hallucis. Abductor hallucis. This muscle is known as the abductor hallucis. Okay. Then, if you would like to know this muscle, which is also present at the floor of the tarsal tunnel, it is known as the quadratus plantae. You can ignore this name, but please remember this one, which is the abductor hallucis muscle. It is the one of the muscles forming the only muscle forming the roof of the tarsal tunnel. This is the abductor hallucis, or ABH. This is the quadratus plantae. Then what are the contents of the tarsal tunnel? The three flexor muscles, the tibialis posterior, the flexor digitorum, and the flexor hallucis, as well as nerves and vessels. And the muscle covering this tunnel is the abductor hallucis, which is ABH. Then this is the causes of tarsal tunnel syndrome, either causes inside the tarsal tunnel like ganglion, varicose veins of the vessels, neuroma, lipoma, sarcoma, tenosynovitis, fibrosis post-traumatic or post-burn. And you see here, this is the tarsal tunnel, and this is the ABH. And you can see soft tissue density here in this area, and it is bright in the T2 weighted image, representing dilated varicosities. And you know that the varicosities, because of the slow motion of the blood, will give signal in the T2 weighted image. And this is a classic appearance of a very bright signal lesion, which shows dots of black signal denoting beating vessels. This is a classic for hemangioma. Hemangioma occupying the region of the tarsal tunnel in the sagittal and in the coronal. But I would like to emphasize that whenever you are going to assess for tarsal tunnel pathology, you should go to the axial. The axial is very important. And this is the case, this is the normal tarsal tunnel, this is the ABH, tibialis posterior, flexor digitorum, flexor hallucis, and the muscles. And you remember this is the quadratus plantae. And here you can see a synovial sarcoma. This is pathologically proved, of course, infiltrating the ABH and occupying the site of the tarsal tunnel. Extrinsic causes outside the tarsal tunnel are usually secondary to trauma or burn, and for example, hypertrophy of the ABH, the abductor hallucis muscle, or the coalition, the fusion of between the calcaneus and the talus, may result in a significant bony protrusion that encroaches significantly on the tarsal tunnel. The last issue in the ankle is the osteonecrosis, which is very common, and the talus is the most common bone in the ankle to be affected by avascular necrosis. However, it may affect the navicular, the head of the second tarsal, or the calcaneus as well. The avascular necrosis of the talus are classified into 4 grades. Grade 1 is just bone marrow edema. You do not see anything in the plain X-ray, but you see positive finding on bone scan, and you see black signal in the T1 and bright signal in the T2. This is the grade 1 avascular necrosis. In the grade 2, you got a cyst, and the cyst is filled with fluid, which is black in the T1 and bright in the T2 weighted image. This is stage 2 avascular necrosis. In stage 3, you got a separated bone fragment that has not been displaced. The only separated, but it remains at its site. This is grade 3. And grade 4, the fragments are displaced away from the parent bone, and this is grade 4. And usually you got osteoarthritis of the ankle as well. Then you see that the ankle is easy, okay? Yes. Now we came to the questions. What do you think about this case? Okay. Let us go to the anatomy first. What do you think about this muscle? Tibialis anterior. And this? Extensor hallucis. And this? Extensor digitorum. And these two tendons here? The peroneus tendons. Then what about this tendon? What is wrong with the tibialis posterior? It is thickened and with abnormal signal. What do you consider this injury? Which one? There are 3 types of injury on the tibialis posterior. Type 1, type 2, type 3. Which type 1? Type 1. Yes, and this is type 1 tibialis posterior tendon injury. Then some of the anatomic details. What do you think about this very famous structure? Yes, anterior tibiofibular or the lateral collateral ligament. And what do you think about this? Very good. And that? Yes, this is the posterior tibiofibular. Okay. Then what do you think about this? Tibialis posterior. Very good. وده flexor digitorum. وده flexor hallucis. ممتاز. What do you think about this injury or this lesion? This patient عنده chronic huh? Yes, very good. This is the sinus tarsi syndrome. Very good. The sinus tarsi is located between the talus and the calcaneus. This is the site of the sinus tarsi in the axial. It contains abnormal signal in the T1 and the very bright signal, fluid signal in the T2, denoting sinus tarsi syndrome. Dislocation of what? No. No, this is the gap between the talus and the end. And if you cut in the gap, you may feel that the talus is slighted, but it's not. Okay. Then anatomy once more. What do you think about this tendon? Tibialis anterior. And this? Flexor digitorum. And this? Yes, this is the inferior transverse. The inner fibers of the posterior tibiofibular is the inferior transverse. And what do you think about this? Peroneus longus. Very good. And this? هو ده شخصيا the posterior tibiofibular. And what do you think about this? Brevis. And what do you think about this lesion? Which type? In place 3. Yes, this is type 3 avascular necrosis of the talus. Then what do you think about this? The arrow points to the abnormality, which is rare. It is not frequent in the clinical practice. What do you think about this abnormality? Anterior tibiofibular. Very good. This is anterior tibiofibular ligament rupture. You see the fibula, there is no groove. Then you are dealing with the anterior and posterior tibiofibular. Then anatomy once more. What do you think about that? Tibialis posterior. And this? Anterior. And this? Extensor digitorum. And this? Flexor hallucis. And this? Which brevis? Meat. As if peroneus brevis. Yes. And this? Endoachilles. Then what do you think about this pathology? Yes, signal inside the Achilles tendon. You may assume this is a bright signal, which means partial tear. If you see that this is an intermediate signal, you may say tendinitis. This is partial tear of the Achilles tendon. Then anatomy once more. What do you think about this tendon? Tibialis anterior. Yes, very good. And this tendon is ligament, the osteoosseous ligament, which is the short ligament present in the sinus tarsi. Okay, what do you think about the pathology? This is the Achilles tendon, which is partial tear and the presence of calcium, denoting this is a chronic injury, and this is a chronic tear of the Achilles tendon. Anatomy once more. This is an axial image, and the anatomy here is very difficult a little bit, but you are already very good in the ankle. What do you think about that? Tibialis anterior. Aywa? Yes, very good. This is the cervical ligament present in the sinus tarsi. This is the sinus tarsi, and this is the cervical ligament. Very good. Peroneus, which one? Longus. Peroneus longus. Okay. What is the pathology here? This أنا عارف إن هي صعبة. This is the fibula. This is the fibula. And this is the groove of the fibula, identifying the posterior talofibular, and the anterior talofibular is the abnormal. With is the abnormality. Yes, thickened with normal signal, chronic injury, and this is the chronic injury of the anterior talofibular ligament. What do you think about this case? Achilles tendon. Yes, the Achilles tendon is markedly thickened with no abnormal signal inside, and this is a chronic injury or Achilles tendinitis. Okay. These two landmarks points to the pathology. No. This is the sustentaculum tali, okay? And this is what? Tibialis posterior, and this is the flexor digitorum flexor hallucis. What's wrong? Yes, the tibialis posterior is markedly thickened and enlarged compared to the flexor digitorum and the flexor hallucis, and this is which type of injury? Type 1. Type 1 thickening, type 2 splitting, type 3 mafish tendon, okay? And this is type 1 injury of the tibialis posterior. Anatomy once more. What do you think about this? Peroneus, which one? Longus. And tibialis posterior. And flexor hallucis. And Achilles tendon. And tibialis anterior. ممتاز اهو. طلع سهلة. شفت الانكل سهل ازاي؟ سهل جدا صح؟